A successful outcome in pediatric cataract surgery is determined by an intact and curvilinear anterior and posterior capsulorhexis. A well performed rhexis helps in maintaining a clear visual axis and centered IOL for life. Due to the highly elastic nature of anterior capsule in children, the chances of radial extension of capsulorhexis to the periphery are high, which not only affects the IOL stability but also the surgical outcome in children. Hence, a well-centered, optimum-sized, regular, continuous curvilinear capsulorhexis that is resistant to peripheral extension is the cornerstone of surgical success in pediatric cataract surgery. The highly elastic capsule, when stained with trypan blue dye, ensures a better grip over the flap. The use of high-density viscoelastic devices maintain the anterior chamber depth, the pupillary dilatation, and keep the flap of the rhexis flattened. Out of the many techniques used to perform anterior capsulotomy, the use of microrhexis forceps to perform capsulotomy remains the gold standard technique. After initiation of capsulorhexis with cystitome, the free edge of the capsulotomy flap is grasped with the rhexis forceps and a centripetal tearing force is applied. The capsulotomy flap is re-grasped at the leading edge of the anterior capsule and then pulled inward. So always remember, grasp, re-grasp and pull inwards. The flap at the beginning needs to be smaller and requires frequent grasping of the edge of the rotating edge of the anterior capsule. A vitrectorhexis can be performed when there is a rhexis runaway, a plaque, or when the anterior capsule is crumpled. The use of retroillumination glow to perform capsulorhexis is also practiced by many, which is also called as coaxial rhexis. Precision pulse capsulotomy is a new technique that can be used as an alternative to manual capsulotomy, which produces consistent, adequate, well-centered capsulorhexis developed by menosis. Probe is collapsed and inserted into the anterior chamber, which is then reopened, centered, and suction is applied. A series of nanoelectrical pulse waveforms are applied through the ring that results in vaporization of water molecules trapped between the ring and lens capsule, causing instantaneous 360-degree mechanical cleavage of the stretched capsule. Hence, the type of anterior capsulorhexis depends on the nature and the density of cataract. Now let's move on to primary posterior capsulorhexis.
Many aspects of pediatric posterior capsule management are different from the technique in adult cataract surgery. There is rapid opacification and fibrosis of the posterior capsule if it is left intact. For that reason, primary posterior capsulectomy and planned anterior vitrectomy are commonly performed in children who are not old enough to sit for ND-AG laser capsulotomy. After aspiration of the lens material, the capsular bag is filled with high viscosity viscoelastic devices and a capsulorhexis is initiated with the cystitome. The posterior capsulorhexis can further be accomplished using capsulorhexis forceps. After adequate vitrectomy, the intraocular lens is placed inside the bag. Some surgeons prefer performing a capsulorhexis after placement of the IOL, which is known as limbus-assisted retropseudophakic vitrectorhexis. It offers a more secure and easier option for an in-the-bag IOL fixation, albeit with a slight compromise on intraoperative visibility. Similar procedure can be done using a capsulorhexis forceps. Care has to be taken that the anterior capsulorhexis is of adequate size and the haptics of the IOL are placed 90 degrees away from the point of entry of the vitrector. Plaque plaques on posterior capsule is a very common scenario in pediatric cataract. A gentle peeling has always should be tried first. Many a times it may not be as easy as depicted. Cutting off the posterior capsule along with the plaque may be necessary. If inadvertently done, it has to be fashioned into a proper PPCR. This is a membranous cataract which resembles a plaque associated with non-dilating pupil. After adequate dilatation, the fused anterior and the posterior capsule was removed using a vitrectomy. When talking about posterior capsule, how can we forget optic capture? And that has been shown in this video. Well friends, there are multiple ways of managing a posterior capsule in a child. The trick is to use the right technique at the right time. Thank you.